Good afternoon, everyone. I am Bianca Durrani, President and CEO of Aperio Philanthropy. Welcome to today's conversation about the role of philanthropy in health equity. I'm going to kick off our conversation by introducing our firm, our partners at NYU, and our moderator, Gianna Jackson. And then I'm going to turn it over to our panel to get started. Aperio Philanthropy is a full-service nonprofit consulting firm that was created by a group of fundraisers who believe nonprofits are vital and it's time to make fundraising simpler, faster, and smarter. We support organizations nationwide with strategic advisory, capacity building projects, and embedded support. As a firm created to drive change, we are thrilled to be hosting this event series with New York University. In the coming months, in addition to this conversation around health equity, we'll also be discussing environmental justice and other important topics. We will be facilitating conversations among these nonprofit leaders, thought leaders, and philanthropists themselves to figure out how philanthropy can become more impactful in these critical years ahead. The Center for Global Affairs at New York University has, since its founding, prepared global citizens to make positive impact in the world. They do this through a variety of activities, including two graduate programs, one in global affairs and another MS in global security, conflict, and cybercrime. They also offer a variety of skills and knowledge-based continuing education courses and offer public events such as this to expand on topics covered in the classroom. They are proud to be the home for the George H. Heyman Jr. Program for Philanthropy and Fundraising. Through their open enrollment courses and certificate in fundraising and new certificate in digital fundraising program, they offer professionally oriented educational options for those who are looking to enter or grow within the fundraising field. Courses are taught by practitioner faculty who bring their vast experience, expertise, and networks to the classroom. So that's a little bit about our host for today, and I'm going to introduce our moderator, Gianna Jackson. Gianna is a corporate social responsibility executive and real estate and investment attorney based in Los Angeles, California. She serves as special counsel at Aperio Philanthropy, providing strategic advisory and support to philanthropists who are looking to expand their social impact. Most recently, she led the Fender Play Foundation that brings music education to children through partnerships with schools. Previously, she served as vice president of CSR at TIAA. And for 18 years prior to that, she held leadership positions at Cigna Corporation, including serving as the executive director of the $11 million Cigna Foundation. She is going to introduce our panelists for today and lead them in a discussion about the role of philanthropy and health equity. And then we will have time for questions and answers from you at the end of today. You can use the Q&A tool to submit questions that will be answered during the Q&A section at the end of today's webinar. With that, Gianna, I'll turn it over to you.
Thanks, Bianca. Thank you for the kind introduction. Good morning, everyone from Southern California, and happy St. Patrick's Day to all, and good afternoon to our friends on the East Coast. Today, we'll be talking about a very timely topic, which is how philanthropy can advance health equity. Today's panel will explore what role can each of us play in driving change. We'll look at how philanthropic individuals, foundations, and companies are approaching this reimagining of health equity and how they should be. Americans give billions of dollars a year to health-related causes. $42 billion last year, which is about 8% of all donations. How can we make sure these investments have a greater impact? In consideration of the nonprofit leaders and fundraisers in our audience, we'll also touch on how you can engage a diverse and dynamic base of philanthropists in your work in this area. To begin, it is my pleasure, as Bianca said, to introduce our distinguished panel. First, we have Daniel Fraschella. He is the Chief Programs and Grants Officer at the Mother Cabrini Health Foundation, which provides grants to improve the health and well-being of vulnerable New Yorkers, bolster the health outcomes of diverse communities, eliminate barriers to care, and bridge gaps in health services. Prior to joining the foundation, he worked at the Archdiocese of New York. Welcome, Daniel. Roger Rennekamp is the Health Director for the Cooperative Extension Section of the Association of Public and Land-Grant Universities, where he focuses on building the capacity of land-grant universities to improve the health and well-being of the nation through community engagement. Previously, he held leadership roles at Oregon State University, including leading 4-H youth development and family and community health extension programs. Welcome, Roger. And last but certainly not least is Dr. Stephen B. Thomas. He is a professor of health policy and management at the University of Maryland and is the director of the university's Center for Health Equity. He is one of the nation's leading scholars in the effort to eliminate racial disparities and racial and ethnic health disparities. Dr. Thomas has applied his expertise to address a variety of conditions from which minorities generally face poor outcomes, including cardiovascular disease, diabetes, obesity, and HIV/AIDS. Welcome, gentlemen, and now let's begin our discussion. So to get started, I'd like to ground our conversation in the unique perspective that each of you brings to this topic. Tell us about how you see the role for yourself and your organization in the fight for health equity. And let's start with your definition of health equity so that we can all start our conversation grounded in a common understanding. We'll start with Daniel.
Thank you. And once again, thanks very much for the invitation. It's great to be with everyone today to talk about this important topic. You know, in thinking about health equity, we at the Mother Cabrini Health Foundation have certainly, been considering a number of factors. And I like to look at a study that was done by the Robert Wood Johnson Foundation about 5 years ago or so, where they presented a definition that I think is a very helpful working definition. Basically says that health equity is the idea that everyone has a fair and just opportunity to be as healthy as possible. And this entails removing obstacles to health and addressing issues such as poverty and the lack of access to good jobs, housing, education, and quality and safe living environments. Things we'll talk about, I'm sure, as we go on as the social determinants of health. And so at the Mother Cabrini Health Foundation, we have as part of our mission to work with organizations across New York State. We focus exclusively on New York to identify those organizations and really partner with them to address these issues and a myriad of issues related to health or the social determinants. And so I see, our role here as one that is able to listen and then support organizations across the state that are looking to advance health equity.
Dr. Thomas?
That pesky mute button. It's so exciting to be here with you today. And, I'm glad you're starting out with the words that we're using, because words matter, definitions matter. And while some differences in definitions may reflect only stylistic preferences, others convey values and beliefs. And I live in a world in academia where we can spend a whole meeting on definitions. And I'm just saying, from these barber poles behind me, from the community, people want to start seeing action. So I'm wondering if we can agree on some things, like the fact that a health disparity is not just a difference in a health statistic or an outcome. According to Healthy People 2030, a health disparity is a particular type of health difference that's closely linked to socioeconomic and environmental disadvantage. And health equity, as Daniel said, is the attainment of the highest level of health for all people. But health equity means that, everyone has a fair chance and a just opportunity to be as healthy as possible. And that's when these pesky social determinants of health come in. So you're going to have some in your audience that are interested in measurement. And let me just say this to them. For the purpose of measurement, health equity means reducing and ultimately eliminating disparities in health and its determinants that adversely affect excluded and marginalized groups. Listen carefully, excluded and marginalized groups. So if an effort doesn't address poverty, discrimination, or health-related consequences for groups who have historically been excluded or marginalized, it's probably not a health equity effort. We need some standards, and I'm hoping that in philanthropy, we set some standards, some some guardrails so that everything's right now, equity is a buzzword. We need to have concrete definitions that lead to action. I'll give you the floor back.
Thank you for that, Dr. Thomas. I'm already inspired. Roger, what would you like to add?
Well, first of all, absolutely fantastic to be with all of you this afternoon. And I would have to say to start off today that as we think about defining health equity, I agree totally with my fellow colleagues who are panelists today. And the only thing I would probably add to what was said is that we as human beings have a way of either providing or denying the resources that people need to be healthy on the basis of a number of different social identities. And that includes on the basis of race, ethnicity, gender, employment, socioeconomic status, disability, immigration status, and even geography. And as I mentioned, those different factors are often used to determine who gets access to what. And when we talk about health equity, and some of the work of our network is funded by the Robert Wood Johnson Foundation, so naturally, you know, we subscribe to that definition, is that, you know, health equity exists when everyone has a fair and just opportunity to be as healthy as they can be. So that's the way we look at it as well. And, you know, when a society is committed to health equity as a common value, people are working together to ensure that everybody, regardless of race, neighborhood, financial status, et cetera, has access to a healthy community of opportunity.
Thank you for that, Roger. So jumping back to Dr. Thomas, and also Roger, I want to hear from you too. Tell me a little bit more about your role of the work, what you do to address this issue, and what your organization does, so that we can understand your unique perspective. Mute.
Yeah, here at the Center for Health Equity, we have a motto: building bridges, building trust, building healthy communities. And that begins by recognizing the privilege that we have on this university campus. Roger, we are a land grant institution. I have to remind my faculty, hey, we're a land grant. We need to reimagine what a land grant institution means in this time that we're in. That it goes back to the time of Abraham Lincoln, that it goes back all that way. We have an obligation to remember that. And so I point to these poles behind me because they're the metaphor of what we are doing to implement what it means to focus on health equity. It means to get off your campus, in our case, and listen to the people who live in the shadow of our building, suffering from the things that we say we're expert in. And we have discovered that the barbershops and beauty salons in Black and brown communities are institutions that need to be mobilized, that can be mobilized, and that we have mobilized to deliver health information and actual health services. And it's been an amazing transformation. It's unfortunate it has taken a pandemic to bring these warriors to the forefront, but guess what? They're here now. And over the course of our talk today, I want to share more of what we're hearing right from the corner barbershops and beauty salons, where disinformation was spreading like wildfire. And now in the sites where we are, with our HAIR network, Health Advocates in Reach and Research, these facilities have become trusted information centers for addressing health equity. You're muted. I'm just going to keep my mic on.
I'm sorry. Roger, tell me about the work that you and your organization are doing to address health equity.
Yeah, John, I absolutely have to. And I have to go back to some of the comments that Dr. Thomas made a few minutes ago. You know, when I was introduced, I was introduced as being affiliated with the Association of Public and Land Grant Universities. And Dr. Thomas also mentioned what land grant universities, and probably for this to make sense to a lot of folks, on our call today, maybe we need to talk a little bit about, what the various roles are of public and land grant universities in health equity. We all know that all universities, all public universities teach. They have students. Without students, they probably would not be universities. And we know that that's common across all universities, is that they are involved in helping prepare the next generation of professionals in the health sciences and the workforce. Some universities talk about themselves as being research universities, where they're involved in making new discoveries about prevention and treatment and things like that. And then some additional universities also provide clinical services through their academic medical centers. But there is a subset of public universities called land grant universities that also have a covenant with the people of the nation and are funded with federal funds to make sure that what happens on campus benefits the communities across the country. So the land grant universities also have branch offices called county extension offices. There's 3,100 of those, one office in every county of the nation, that employs 31,000 people across the country, trying to engage with communities to bring the resources of those universities directly to those communities based on their needs. And Dr. Thomas talked about, sometimes we get caught up in an expert model of teaching people what they need to know and how to be healthy, but we are in the process of forming from an organization that really relies on an expert model to one that is more of a community engaged model, where we listen first. And that transition is actually being supported by the Robert Wood Johnson Foundation, and it have been with us for several years in terms of trying to change the way we do business, to really engage with, listen to the voices of people, raise up the voices of people who live in communities, and then bring the resources of the university to bear on those issues in terms that make sense for them. So that's the work that we're doing through the land grant university system.
Thank you so much for that, Roger. Now I want to dig a little bit further into what is the change that we would like to see happen. So Dr. Thomas, I'm going to start with you. And as we've touched on a couple of times, it's an understatement to say that healthcare has been top of mind for the last couple of years. How would you summarize what we've learned so far about ourselves and our national healthcare system through the pandemic?
Well, thank you for the question. And I think that I love the fact that this is one of the silver linings of that pandemic, that we're now on Zoom and coming together in ways that may have been available to us in the past, but we just didn't do it. And so I'm glad that we're seeing we're going to keep this thing moving forward. If I might, on the land grant, because at the core of what I think the pandemic has exposed is something we've known a long time. The history of racism and discrimination in our healthcare system would be easy to ignore were it not so well documented. And it even is documented in our land grant. We have the 1890 institutions, and my friend there, Roger, knows, and that's when the historically Black colleges and universities were established. So the issue of segregation and racism was happening even back then. Fast forward to today. Of all the institutions in our society, one would hope that healthcare would be the place where people are judged not by the color of their skin, but by the needs that they have in terms of serving them. And all of our health professionals take an oath of ethics. So how could it be in our healthcare system that we see racism and discrimination? All we have to do is look at the Institute of Medicine, 1990. I believe that was the report, Unequal Treatment, Confronting Racial and Ethnic Health Disparities in Healthcare. The documentation's been there, but the pandemic made a very clear distinction between medicine and medical care and public health. And I think that's where this conversation is. And if I would say to my philanthropy friends, make that distinction between medical care, because a lot of investments from many of the groups we've heard of are in medical care service delivery after the fact somebody's sick. Public health is a little bit further upstream. And how do we keep people from getting sick? And now more than ever, we know now more than ever how to do that. So I think that's the key. And to do that, we need to build trust in communities that have lost trust in us. And they've lost that trust in legitimate ways. One need not go all the way back to the U.S. Public Health Service syphilis study. For many of the people we talked to in the barbershop, it's what happened to Uncle Johnny, last month when he went in the hospital, or what happened to a grandmother who couldn't get a COVID test. They see it every day. It's interpreted as a continuation of racism and discrimination. I'm so happy we're having this conversation here, because if we put that front and center, we actually might be able to move the needle in ways that save lives.
Thank you for that. So, Roger, in building on what Dr. Thomas is saying, we're becoming aware of these issues as a general public, so that's great, but it can also be overwhelming. You are all working to find solutions, but tell us about some other ways that we can all be a part of that solution. What are some of the emergency solutions that you're seeing across your community and beyond?
Happy to do that. And I would probably summarize some of the things that Dr. Thomas has said in terms of a short phrase that I have heard repeated many times, is that we don't have a healthcare system, we have a sick care system in our society. And public health is really about, in fact, establishing kind of a system that really works upstream to help people stay healthy rather than simply treating them after they have gotten sick. Now, I want to start with a public health parable here that I'm sure Dr. Thomas also teaches to all first-year public health students. So he may tell it better than I do, but as the story goes, and many of you in the audience probably today have heard this too, but as the story goes, three people decide to go for a hike behind, next to a scenic but very wild river that eventually drops over a falls. And after hiking a short distance, the three people notice that there's a person in the rapids calling for help. And then the hikers respond and pull the person out of the river. But shortly after, they notice another and pull a second person to safety, and then another and another. And then the three hikers wonder what it is that they can do about this. And so eventually one of the hikers volunteers to stay behind and watch for other people, in the river headed for the falls. And the other two head upriver to see if they can figure out what's going on. So still noticing that there's people caught in the rapids headed for the falls, two hikers reach a point in the river where they discover a large stash of life preservers, and they decide that the best thing they can do is toss life preservers to the people struggling into the river. But they also know that sooner or later they're going to run out of life preservers. So they decide that one of them should stay behind again and continue to pass out the life preservers as people are floating down the river in peril of going over the falls. But the final member actually continues upstream until they discover that a bridge has been washed out from a recent flood. But regardless of the fact the bridge is gone, people are still trying to cross the river to obtain the necessities of daily life, but they're being swept away from the current. So, they begin to think about, well, what is an appropriate solution? We can continue to pull people out, as the emergencies arise, and that's important stuff, right? We know we need emergency services. We know we need primary care. We know we need urgent care. But, and we continue to invest, and we can continue to invest time and year after year in providing stopgap measures at that individual level. And granted, those emergency services are needed, but we also need to work upstream and to invest in creating thriving communities that provide all people with the resources they need to experience lifelong health and well-being. So secondly, one of the things we also know is the life expectancy, and maybe everyone may not be aware of this, but life expectancy in the United States is declining. And yeah, a lot of you said, well, yeah, of course, COVID, was responsible for a big part of that. And yes, it has been in the last 2 years, but life expectancy in the United States peaked in 2014. And despite the advances we're making in medicine and clinical care, life expectancy reached its lowest level in 2 decades in 2021. So what's the cause of the decline? Well, we know that only 30% of a person's health is determined by their individual behaviors. The rest by factors beyond their control, such as the context in which they live their lives. As a matter of fact, in some of the nation's largest cities, life expectancy varies by as much as 30 years from zip code to zip code. 30 years. And those zip codes may only be 20 to 30 miles apart at most. So is it that people in the zip codes don't care about health or don't mind dying in their 50s? I don't think so. Rather, it's that systematic disinvestment in communities of color and new immigrant populations, and even the rural poor, that put them at that disadvantage. And as Dr. Thomas said, it's not just a chance occurrence. It's because we have made policy decisions and to provide resources in some places that are not available in others. So as we think back to that parable that I talked about before, the folks pulling people out at the last minute, kind of a response, aligns pretty well, I think, with, the work that we do to really take care of people after they become sick. The life preservers might include things like seat belts, and things like that. And maybe in some cases, educational programs to help them make the right decisions. And granted, there is a lot of opportunity for people to understand science-based decisions about health and their health behaviors, as what Dr. Thomas does through the HAIR project. But at the same time, we also need to really look at the level of policy systems and environmental changes that create that opportunity for all people to experience optimal health across their lifespan.
Thank you for that. Very, very illuminating. Thank you. So now we're going to start to focus a little bit more on what philanthropy can do to help. How can we address these issues? And I'll start with Daniel. As a funder, what opportunities do you see for philanthropy to move the needle on health equity?
Thanks. I think I'll speak really just on behalf of the Mother Cabrini Health Foundation, because we're a very new funder, just entering our fourth year. And I think we're still learning a great deal about the needs across the state and the best role that we can play. So I'll just, really speak to that element of the role philanthropy can play and sort of how we're thinking about it. Mm-hmm. And I'm struck by the sort of experiences and work that both of my colleagues have mentioned. Dr. Thomas with the Barbershop as a place of real connection to communities. And for example, we've funded a project with an organization here in New York City called the Arthur Ashe Institute for Urban Health, where they're going to be installing kiosks to have sort of a screening tool for the social determinants of health in a number of barbershops and salons in minority neighborhoods. This is the kind of thing that we're looking to support when we think about how philanthropy can be involved. This is one example. And to Roger's work, we fund similar kinds of innovative projects with the cooperative extensions across New York State, at least a handful of them, where again, we recognize that there are often organizations, sometimes very small organizations, that play a really crucial role in providing needed services or communications to underserved communities. And so I think that's one of the ways we've approached it, is to look for, especially some of those smaller organizations, to be responsive to what they're saying. I think one role that philanthropy can play is to adopt a posture of listening and hearing from, inviting in the participation of the communities themselves, community members themselves, to understand what their needs are, rather than assuming, we have sort of certainty or clarity around the needs. I hope that's something that we've started down the path of doing here, and certainly think that's something that, stands to have a positive impact as we move forward.
Great point, Daniel. I think being sure to engage the community, and also, as Dr. Thomas mentioned, the importance of trust. That's how you build that trust to be able to give that information. So Roger, what do you wish that philanthropists knew about the impact they could make?
Well, I think I think the first, I want to reiterate, I think some of the comments that you just made in terms of, it really begins with listening and, listening and trust, and that kind of thing is lots of times we know, and I'm based here in Lexington, Kentucky, and spent a lot of time, I think, in and around rural areas, particularly in Appalachia and things like that. And one of the things we hear, both about universities and government, and even philanthropy sometimes, is don't come save me again. Okay. And we do the same thing, I think, in some of our urban areas and that kind of thing, is that sometimes universities have this way of coming and studying people and taking from people and publishing articles about them and that kind of stuff, and actually never doing anything to solve the problem in those particular communities. So it does come with, and those type of things erode trust. So I think one of the things that we really have to do is make sure that we maintain trust, be genuine, and be committed to listening at the beginning. And then as we talk about different examples of how, in fact, philanthropies can help, several examples happening across the country. One of, a lot of times we see philanthropies investing in building walkable communities, because in some communities there is no place to go outside, and really connect with the natural world and recreate and engage, and actually engaged in physical activity. The other piece, lots of folks, may not be aware that there are counties in this country that do not have a grocery store. There are, and some folks would be surprised at where some of those are. My time at Oregon State University, there were several counties where there was no grocery store. It was really just a little bit of fast food and some convenience stops, and that's all that was available. We're doing some things, I think, in the state of Florida, where county extension offices that I talked about are also telehealth sites where people who do not have broadband access to the ability to fully engage in a telehealth appointment can come to that county extension office. So building, some of the modules and some of the components that those local providers that Daniel talked about, might actually have the opportunity to be a telehealth site. There are other issues with infrastructure. Why is it that certain people have to drink drinking water that is laced with toxins and carcinogens? It makes no sense. So investing sometimes upstream in infrastructure makes sense. And so those are just a few examples of the ways that, and those might be non-traditional ways of thinking about things. Whoever thought about infrastructure and replacing, public water systems as being what we typically thought about when we think about health care? But those are the things that help people remain healthy, of course, across the course of their lives, that may not necessarily have to do with going to the doctor to get better, for when you have a particular malady.
Great answer, Roger. Definitely important to focus on the whole person and all of their surroundings and the impacts on their health. So Dr. Thomas, I'm going to ask you too, to tell me what you wish philanthropists knew about the impact they could have. What do you wish they knew?
Well, I wish they knew that moving, I'll do it like this, and I hope I get invited back. But sometimes the perception is that the philanthropists are like the flavor of the month. Okay, so here's a flavor, and it will run for that flavor for 5 years. And now we're going to completely switch to a totally different flavor. And once you're out of favor, you're out of luck. In other words, some of the things that we stand up with philanthropic resources, when those resources go away, those innovations go away. When they ask me the question, what's your sustainability model? I used to say, you want me to cure cancer in 2 years? I mean, we got to get realistic that this system is broken. We got billions of dollars circulating in the broken side of the system. And our innovations that get stood up don't get a connection sometimes. I love what my friend Daniel is doing with the Arthur Ashe Institute to put the kiosks in those barbershops. Because one of the things that we found when we do have clinical partners and they do come in and do the screenings, guess what, Ms. Jackson, they leave with all the data. And so I'm left with no data to tell to my foundation people our outcomes. So let's reimagine outcomes. We're talking social determinants and this broader vision and a more holistic approach. But if all the outcomes that you measure for success are these clinical outcomes, and then we're back in the same kind of boat. So I think we need a period of reckoning and humility. That's what the pandemic has provided. We thought we were the best healthcare system in the world. Well, maybe if you need a double lung transplant and intestinal transplant, yeah. But when it comes to the very things killing people, like a pandemic, maybe a D. A from the bench, vaccine in record time. But getting it into the arms of the most vulnerable, that's public health. That's where that broken bridge was. And we did a terrible job. And now we're faced with public health professionals coming under attack. How can philanthropy help there? How about those health directors around the country who had death threats, who had lost their jobs? I didn't see anyone rushing out to help them. Our science is coming under attack, and we don't have countermeasures. So let's recognize, yes, Dr. King said, of all forms of injustice, injustice in healthcare is the most shocking and inhumane. That was a nonviolence. I think we have to turn the heat up and maybe listen. I'll go with you, Roger. Let's go back to the 1800s. Let's listen to Frederick Douglass. Frederick Douglass said, if there's no struggle, there is no progress. Those who profess to favor freedom yet depreciate agitation are men who want crops without plowing the ground. They want rain without the thunder and lightning. They want the ocean without the awful roar of its many waters, end quote. That's what we're hearing out there, the awful roars. The community saying, are you going to give us the vaccine and then abandon us with diabetes, obesity, and living in food deserts? Is that what you're going to do? If we do that, and it's happening right before our very eyes right now, we will have lost the opportunity to rebuild relationships with the vulnerable communities. So the power to convene, I think that philanthropy has the power to convene that is as powerful as the federal government. And because of the polarization out there, the federal government has less power to convene all of us. So philanthropy can bring us together across all that we think divides us. And I love that. We can bring together the people who control the system with those who have lost all hope in it. And in these Hollywood squares, come up with a co-created solution together. If this pandemic has not been disruptive enough for us to say, it's time to regroup, and now we throw a war on top of it, if that's not disruptive enough, I don't know what is. This is our moment. So philanthropy, come help us make sure that we stand up the innovations that came through the pandemic, the silver linings, because the governments are now backing off as the surge recedes. They're not calling the meetings anymore, Daniel. They were the ones convening. Now that staff is going back to their silo. Don't let them go back. And so where you put your resources is then the question. Do you put those resources in that broken system? Or do we see some of these innovations that can be scaled to a point where it can be a permanent innovation, a permanent moving the needle in the direction of improving the lives, as we said in our definition, of those who have been most vulnerable due to systematic discrimination and inequality in our society. I think we can do that.
Very powerful. So in about 5 minutes, we'll be moving to Q&A, but I wanted to touch on just a couple of additional topics. Starting with Daniel, what are some of the tactical ways that you think health foundations can center equity in decision-making and grant-making to support organizations serving those most at risk?
Thanks. It's a very important question, and one that I hope is increasingly at the forefront of funders' considerations in decision making. I mean, understanding the participation of members of the community that's being served in a given organization that might be applying for funds. Who's in the leadership roles? What's the board composition look like? Are we sure that organizations are reflective of the communities they seek to serve? Is there a way that we can boost, if you will, and support, again, I keep coming back to some smaller organizations that we've just encountered at working across New York State that might not, on paper look like the perfect grantee or have the perfect application. Well, the reason they might not have the perfect application is because they're so focused on meeting the needs of those in the community that they serve that they don't have a development office, they don't have a grant writer. And is there a way to account for that and to calibrate our decision-making process in such a way that we can understand really where various organizations are with respect to their capacity to do the kinds of things that funders typically look for, and understand that maybe we're the ones on the philanthropic side that could do more to adjust and be flexible and sort of reach and think outside the box to support the work they're doing, rather than maybe expecting that they'll bend to whatever process we have set up. I think that's a key consideration to ensure that equity is a part of our process, and everything we do is keeping that in mind when we're thinking about how to invest our resources.
Great, thank you. So I will ask one last question to the panel, and ask each of you to just briefly touch on it. Thinking about our audience, we've got nonprofit leaders, we have funders, we have fundraisers, donors. So give our audience some advice on how they can have the greatest impact in this area, and how they can cut through the clutter and all the noise that they're hearing about this topic, and really find effective ways to support health equity and to address health equity in their communities and tell their stories in a more compelling manner. So I'll start with Roger.
As I tell many of the folks who are affiliated with our county extension offices and often on campus, one of the things that I really encourage them to do is find a trusted community or cultural guide, somebody that can help you walk in the shoes of people in that community, immerse yourself in those communities, so that it's not just the data that are telling you, where those places are where you might need to be, where you might need to invest resources, but data tell us what the problem is and the places where it might exist, but it's the people in those communities that tell you why. So find that person who will introduce you to the communities that you want to serve, and listen to what they have to say. That would be my key advice, is find that trusted community and cultural guide to help you understand why things are as they are in a community.
Great advice, Roger. Dr. Thomas, any advice for our audience members on how they can have a greater impact?
They need to use this pandemic as a reset. They need to use this pandemic as a time of recognizing that there's some things we don't know. We think we're great, but you know what? This has humbled us. Let's lean into that humility and go to the community, both listening, but they're suffering. And so we can't listen while they're suffering. I think it's also time for less talk and more action. And so in the conversation I hope we're going to have is how to do that in a way that is respectful. And that Institute of Medicine report, and I'll close with this, said that the disparities were not necessarily because of racism, like people actively being racist, but unconscious bias. I thought that was interesting. So that means a retooling of our healthcare infrastructure and our training programs to realize that unconscious bias is real and has life implications. And the pandemic has exposed that. That may mean new training platforms. We have to address hearts and minds as well as policy.
Yeah, so important. So Daniel, I will combine what we were just talking about with a question that came in from the audience that really touches on something Roger mentioned about having an advocate or a validator to bring you into the community. How do you or other nonprofit leaders that you've worked with bring people from the communities that have been historically disenfranchised to the table? How do you engage them in the discussion and conversation so that they can help shape the solution?
Yeah, thanks for that. I do think there could be a number of ways that this could happen. In thinking about working with our partnering organizations that are in the communities across the state, setting up meetings where we can, ask them to bring in some people that can then share with us, so sort of direct firsthand, what they're seeing, what their needs are, may be on a given topic, to again stretch a little bit to find those organizations that might be under the radar in terms of the normal groups that receive funding. Can we find them and make connections, build relationships there? Because sometimes very small organizations, faith communities, other entities that might not be, again, the typical organizations that are on our radar screen as funders, are the places that people in need and marginalized people are turning. Think about the situation for a number of different immigrant groups here in New York State, and those without proper documentation, and the fear around educational or the fear around, I should say, accessing health services, and trying to understand what's the right thing to do, and is there some danger in going to see a doctor to get a vaccine? Sometimes they'll turn to their church or their some other local entity as kind of the only trusted place. And is there something more we can do to work with those kinds of organizations too, to help them and to really hear what they're saying in terms of the needs of those that are really on the margins?
Great point, Daniel. We've had a number of questions that are sort of along those lines. Dr. Thomas, I'll share this question from an audience member about what do we do to empower folks in those communities to really take charge and understand the issues, but also really help make a difference, be a part of the solution?
I love that question because it's something I had to learn from the barbershops. They said, Dr. T, and that's what they call me in the barbershop, Dr. T, we already have power. And they're absolutely right. So to the person who asked that question, the community has power. I think we have to go there seeking their wisdom. And that's where the listening sessions come in. And there are new methodologies out here that we can use in terms of convening people. I bring people together and they have no patience sitting in a room being lectured to. We do that all the time. So I think we need new teaching methods because people have different learning styles. And so we've used something called human-centered design. And we literally have a design studio where we're literally building things, building prototypes. And in the course of building something, even if it's just with duct tape, conversations happen between people who otherwise would never have met. I think the theory of weak ties is important, bringing people together who otherwise, Daniel, when you bring people together with Arthur Ashe in that barbershop and your board members, they would never have met were it not for that moment. We need to create more space like that. Roger, I want you to take me with you to Appalachia. Help me understand my brothers and sisters in Appalachia, that we have more in common than we have, and they have divided us in ways that are just crazy. This is our moment to come back together. So the power to convene, I found the barbershops to be the stable place. During my early days, it was the church. When it came to HIV/AIDS, we made great progress there. I think that the COVID has exposed another asset in the community, and that's the barbershop and salon. And guess what? They're small businesses. They're not private, nonprofit, which means now we have another partner to bring to the table, and that's our chambers of commerce. That's our chambers of commerce. We've been getting calls from local chambers of commerce saying, we want to help our small businesses, our cosmetology businesses. Can you help us bring health services into these barbershops and so on? I thought that was amazing. It wasn't a hospital, it was a chamber of commerce. How might we?
Thank you so much for that. We have another question from the audience, and they're, I think, really looking at, from the nonprofit's perspective, how to reduce barriers to access funds from foundations who sometimes make it difficult for community organizations to be invited to respond to RFPs. So how do we correct for this and create greater equity on who can apply for funding in this area? Do you have any experience with that? Maybe Daniel, do you have a thoughts on that?
Thanks. I don't know that beyond sort of what I had said previously, anything specific comes to mind. I really do think it's important in this moment with this effort towards health equity and the recognition of its importance that on the philanthropic side, we think creatively and outside the box about how can we really do more. And I think that starts with a focus on the communities in need more than what we think we might need in terms of the process. And so can we readjust some of our parameters, our framework, just the way we engage and work with partners to ensure that that there isn't an exclusion that occurs by virtue of an overly cumbersome process or reporting requirements that might be just not plausible or feasible given the situation that organizations are in. I really think it's incumbent upon us to think about that and try and devise processes that really support communities and the organizations working to serve communities rather than impose upon them.
Thanks, Daniel. I think we've gone through all of the audience questions, but actually I have a question for the panel. So when I first met Dr. Thomas in 2006, I was with the Cigna Foundation, and we had started working on health disparities and how to address some of these issues way back when. But we focused a lot at that time at Cigna on the patient-doctor relationship and really looking at training, going into the medical schools and talking to medical students about this issue and making them aware about those unconscious biases or other ways that interfere with clear and good communication between doctors and patients. Do you all still focus in that area, or is it more kind of community-based, getting them the information through alternative means like barbershops?
It's a yes and on the doctor-patient relationship side, we've just flipped it over. We've turned it upside down. So when the physicians, and we take physicians into the barbershops and they love it. And they say things like, this is our social medicine month. Oh, you get 1 month and then we move on to something else. But when they're there, you know what they say? We love this. This is why I became a doctor. This is why I wanted to be a nurse. Somehow the way we're training them takes that out of them. So I think what our barbers said when the doctors said, we're going to adopt these barbershops. You know what the barbers and stylists said to me? They said, no, because that one guy, he doesn't need to come back. How about we adopt the doc? Flipping it on its head. And now the barbers and stylists are saying to Dr. Roger, will you come back? Will you come back on a monthly basis? Will you be the person who comes? Let that bonding occur. So there are a lot of things that can be done. One need no longer be tethered to a hospital or a clinic. Let's bring those miniaturized diagnostic tools into the barbershop salon. So just changing the venue, I think, can help. And last but not least, technology. These are sensitive issues. You've seen people lose their jobs by saying the wrong thing in a meeting, or a coach or whoever. These are the celebrities, but some of us experience that. We don't end up in the newspaper, but it's no less traumatic. New training opportunities. And I think that computer simulation could be one of those things where you can practice those diversity, inclusion. You can practice microaggressions in a way that you're emotionally safe, and you can practice them in a computer simulation. That is one of the things we're working on right now, Ms. Jackson, a new platform for training health professionals to address implicit bias. And then on the barbershop side, we're actually a cartoon book about how to protect yourself from COVID. Scientifically sound, but in a format more inviting.
Nice. Thank you so much. Thank you. This has been a great discussion, and we've got about 5 minutes to go. So I just want to give each of you less than a minute to tell us what one takeaway do you want us to leave with? I'll start with Roger.
Well, as I think about it, I think just building upon some of the things Dr. Thomas just said is, I think the one piece is, look for those safe places in communities where people already congregate, and that kind of stuff. It may be a barbershop someplace, and in our history of being based heavily in agriculture over our years, it might be kind of the feed store where farmers gather, where you can ask them questions like, have you gotten that booster yet for COVID? And that kind of stuff. It's who are those trusted ambassadors, in those communities that can help get messages across. But then at the same time, also look at those systemic barriers that some people are facing to achieving optimal health across their lifespan.
Thanks, Roger. Daniel, any last thoughts on a takeaway for all of us?
Or just to echo some earlier themes about the importance of focusing on and investing in, on the funder side, the social determinants of health. That, if we're going to really make strides towards improving health equity, we have to focus on those other aspects that are such a big part of health outcomes. And it's a collaborative effort. Everyone will have a role to play, from government to philanthropy to the private sector. But we can't lose sight of those really crucial factors when we think about this issue.
Thanks, Daniel. Dr. Thomas, you're going to get the last word here.
I'll be real fast. Sometimes when we come together like this, we say, oh, we're talking to the choir. And you know what? Fine, but the best choirs practice. I don't think we practice enough. We come away from this inspired, and then we go out and we hear the pushback, and we don't know how to respond. I think we need to bring those tough conversations right here and practice how to respond to the pushback, practice how to respond to the, are you lowering our standards? Are you giving grants to groups that are really not capable of fiscal responsibility? Let's have that tough conversation right here and practice how we do better.
Thank you so much. This has been a wonderful conversation, fascinating. I've learned a lot, and I'm just so grateful for your time, your contributions, and your insights. We all are. I want to thank Michelle D'Amico and our friends at NYU who helped host this event. Michelle has put some information into the chat for everyone to see about our upcoming events. Thank you all for attending. Our next event will be on April 7th, where we discuss how philanthropy can advance environmental justice, and on May 5th, how philanthropy can advance economic equality. So you can RSVP to attend those events. There's a link in the chat, but there will also be a follow-up email to every one of the attendees with a recording of today's event, and also it will be posted on various social media sites. So again, thanks everyone. It's been a wonderful discussion. I really appreciate it, and have a great day and enjoy St. Patrick's Day.